Ma'am, we are on live and we are starting session.
Yeah.
Yeah, very good evening, doctors. I am Dr. Stalin on behalf of Shield Healthcare, welcoming you all for today's webinar. The topic for today's webinar is pelvic inflammatory disease and female infertility. I would like to welcome all the participants and I request them to post their queries, if any, in the chat box so that we can have a short Q&A session at the end of this presentation. Now it's time to introduce our invited speaker for the day. Dr. Punitha Rajesh ma'am. Madam has done her MD OG, FSC and DG is from Germany. Madam is currently the consultant obstetrician and gynecologist, fertility specialist and laparoscopic surgeon at Sridevi Hospital and Fertility Center, Trichy. Madam hold various positions in the past, like Madam was the past secretary of Trichy OG Society, executive committee member of IAEC, and Madam has also been a part of various organizing committees of various state, national, international conferences. Madam's special interest is infertility and gynec endoscopy. So with this short introduction, I welcome you, ma'am. I'm handing the session to you for your presentation, ma'am. Welcome.
Thank you for those nice words, sir. And I welcome everyone who has logged in for this session and hope the discussion at the end will be helpful for everyone of us. Can we start the slide?
Yes. Ma'am, you are having the slides, ma'am?
I think I have it in the WhatsApp, and can I throw it from the WhatsApp?
Yeah, ma'am.
I shall try.
Yeah.
Do you have the slides with you?
1 second, ma'am. Let me check, ma'am. Ma'am, I have projected the slide from my end.
Yeah, thank you. Let me check, because I have signed in through the mobile. It's not clear for me. Let me see whether I can open my slides if possible. It's not opening. Okay, I shall read from your slides only.
Yeah. Yes, ma'am.
So the topic I'm going to talk about is pelvic infection. That's the pelvic inflammatory disease and female infertility. Next slide, please. So PID is a major comorbidity in young sexually active women, and the prevalence of PID is increased worldwide. Usually it results from sexually transmitted pathogens ascending from the lower to the upper genital tract. PID is the most important topic to discuss about, as it can have long-term sequelae. Next slide, please. So the PID, when do we call it as a pelvic inflammatory disease? Whenever there is inflammation in the upper reproductive tract. Like if it affects the ovaries, then it's oophorytis. If it is both the ovaries and the tubes, it can present as tubo-ovarian abscess. And if it affects the endometrium, it can cause endometritis. And the tubes alone, it's the salpingitis. And if it is the peritoneum, that the pelvic peritoneum which is affected, then it's the pelvic peritonitis, and sometimes we can have a pelvic abscess as well. Next slide, please. So how does the pathogens enter the upper reproductive tract? Through the cervix. So usually there will be cervicitis, then the pathogens ascend and infect the endometrium and present as endometritis. And if the tubes get affected, then it's salpingitis. And if the ovaries get affected, then oophorytis and tubo-ovarian abscess can occur. And eventually the peritonitis. Next slide, please. So what are all the long-term sequelae of pelvic inflammatory disease? There will be chronic pelvic pain. The patient will be complaining of pelvic pain most of the times. And obviously, when there is organism affecting the reproductive system, infertility can affect due to various reasons, like how the PID is going to affect the reproductive tract and how the infertility is caused. Will be knowing from the successive slides. And there can be ectopic pregnancy. Obviously, when the tubes are affected, there is increased chance of getting an tubal ectopic pregnancy. Next slide, please. What are all the causative organisms? Mostly it's polymicrobial. And the commonest organisms we know to cause PID are Neisseria gonorrhoeae, Chlamydia trachomatis, and other less common organisms causing PID are Gardnerella vaginalis and anaerobic bacteria like Prevotella, Atopobium, and Leptotrachea, and Mycoplasma genitalium. Next slide. Who are at high risk of getting PID? Women belonging to younger age group, that is less than 25, and those who have multiple sexual partners, and if there is any past history of sexually transmitted infections, and if there is any history of termination of pregnancy, and if they had underwent any procedure like hysterosalpingogram or in vitro fertilization, and sometimes silent sonohysterography as well. And if the woman is a smoker, the chance of getting PID is increased. Next slide, please. What are all the usual symptoms that we can diagnose PID in such people? Sometimes they'll be asymptomatic. When they come for infertility, when we evaluate them for infertility, then we come to know that the patient is suffering from PID. And when the symptoms occur, mostly it will be of lower abdominal pain, which is typically bilateral, and there may be fever on and off, and usually of low grade fever. And when there is acute exacerbation, in those times, there can be high fever as well. There will be a history of deep dyspareunia, and there will be pelvic pain most of the times. And there can be abnormal vaginal bleeding, and there can be postpartum bleeding, intermenstrual bleeding, and increased bleeding during periods. And there could be abnormal vaginal or cervical discharge, which is often purulent. Next slide, please. So fever, obviously, whenever there is infection, there will be increase in the body temperature. And on examination, there could be lower abdominal tenderness, and there could be cervical motion tenderness on by manual examination, and we could visualize the abnormal discharge either from the vagina or from the cervix, which is mostly virulent. And the slide shows the gonorrheal cervicitis and the chlamydial cervicitis. But clinically, we cannot confirm a pelvic inflammatory disease. What are all the differential diagnoses? We need to rule out ectopic pregnancy when these symptoms, we come across these symptoms and signs, or any ovarian, condition like ruptured ovarian, hemorrhagic cyst, appendicitis, irritable bowel syndrome, inflammatory bowel disease, urinary tract infection, bowel torsion, and psychosomatic pain. Next slide, please. So how do we diagnose? The investigation available to diagnose PID are really not sensitive. So we need the blood test. We do the complete blood count, and we see the neutrophilia suggestive of acute inflammatory process, and reduced white cell count, that is neutropenia in severe infection, and raised CRP. CRP will be increased in any infection, so obviously CRP will be increased and ESR will also be increased. Next slide. And when we do the endocervical swab, it should be placed in transport medium and it should reach the lab within 6 hours. We have to look for Neisseria gonorrhea to confirm the infection. And for chlamydia trachomatis, we do the nucleic acid amplification test. That is more sensitive than culture. Next slide, please. So other investigations, ultrasound, we cannot, it's not the test for diagnosing pelvic inflammatory disease. But we could identify the adnexal mass if present, and hydrosalpinx or fluid collection in the POD can be identified. But usually the tenderness, the probe tenderness can give us a clue. The laparoscopy, we could see the adhesions, and especially the perihepatic adhesions, the Fitz-Hugh-Curtis syndrome will confirm the chlamydia trachomatis infection. But we do not advocate laparoscopy immediately because it's not cost effective. Next one, please. So we can do who test positive for gonorrhea and chlamydia trachomatis. We can do other tests for ruling out other sexually transmitted infections like HIV and the viral test and hepatitis. We have to look for hepatitis B and C also. And we need to screen the partner as well. Next slide, please. So coming to know what PID is, we can now, from the upcoming slides, we know how the infertility is caused. Next slide. So according to ACOG, 1 in 10 women with PID becomes infertile. So that is the theory is the pelvic infection will lead on to scarring of fallopian tubes. Obviously, when the fallopian tubes are not functional, not able to function either due to some anatomical alterations or the ciliary epithelia is lost, now obviously the infertility is caused, and it's known as the tubal factor. Next slide. In gonococcal and chlamydial salpingitis, the microorganism ascend by surface extension from the lower genital tract through the cervical canal by way of the endometrium to the fallopian tubes. Microscopically, the endosalpinx is inflamed and edematous, and there can be additions of the mucosal folds, destruction of cilia, occlusion of infundibulum, and production of biosalpinx. The gonococcal infection may spread beyond the endosalpinx with possible focal abscess formation and perisalpingitis. Next slide. In some cases of non-gonococcal salpingitis, particularly with M. hominis, the pathogens may enter through lesion in the cervix or endometrium and spread to the parametria and tubes through lymphatics and blood vessels. The inflammatory swelling that affects the parametria and the tubes is more pronounced than in gonococcal salpingitis, but the endosalpinx is usually intact. Next slide, please. It's very difficult to see. So we could see how the pathogens gain access. The sequelae of PID that are responsible for infertility include chronic interstitial salpingitis, hydrosalpinx, salpingitis ischemica nodosa, and periadnexal adhesions. Infertility may also occur because of abnormal secretory, ciliary, and peristaltic function of the fallopian tubes. The postulated interrelationships of STDs and endogenous organisms in the pathogenesis of tubal infertility secondary to PID is given in the flow chart. Next slide, please. So, the cause of tubal occlusion by history and ancillary tests can contribute to the assessment of prognosis. We know whether the tubal anatomy can be repaired or not from the cause of the tubal disease. Severe male factor combined with tubal disease in the female partner is an indication for advanced laboratory techniques in assisted reproduction such as IEC. Next slide, please. It is widely acknowledged that pregnancy outcome after tubal surgery is time dependent. Most physicians advise the patients to opt for IVF at 12 to 18 months after unsuccessful surgery. So usually I think it's 6 months. And a review of the world literature indicates a mean intrauterine pregnancy rate of 58% after tuboconval anastomosis, with an ectopic pregnancy rate of 4%. It is reasonable to expect a continued improvement in pregnancy outcome for IVF procedures. Data from large US centers indicate a 40% to 70% cumulative delivery rate after 3 IVF cycles in younger women with tubal disease and without associated male factor infertility. Next slide, please. And according to AJOG, the effect of acute pelvic inflammatory disease on infertility, the study is done on total of 415 women treated for laparoscopically verified pelvic inflammatory disease. And it was reviewed after 7 years and 5 months. And 88, that is 21.2% of these women were involuntarily childless after 1 or more infections. Tubal occlusion was diagnosed after 1 infection in 12.8%, after 2 infections in 35.5%, and after 3 or more infections in 75% of women. Tubal occlusion was more common after non-gonorrheal than after gonorrheal salpingitis. Infertility varied with the inflammatory changes seen at laparoscopy. The ratio between ectopic and intrauterine pregnancies after the infection was 1 in 24. 1:24, sorry. Next slide, please. And another study shows vaginal microbiome and sexually transmitted infections. I studied on this, and vaginal bacterial communities are thought to help prevent sexually transmitted infections. Bacterial vaginosis is a common clinical syndrome in which the protective lactic acid producing bacteriae or supplanted by a diverse array of anaerobic bacteria. Epidemiologic studies have demonstrated that bacterial vaginosis is associated with a markedly increased risk for acquisition of sexually transmitted infections. Transmission of this is sexually transmitted infection is also associated with BV, since BV increases viral replication and vaginal shedding. BV is an independent risk factor for severe reproductive tract and obstetric sequelae, including preterm delivery and low birth weight, development of PID, acquisition of sexually transmitted infections, and acquisition and transmission of HIV. Next slide, please. So the vaginal microbiome and PID. So it's the lactobacillus. We know it's present in the vagina and it produces lactic acid, and this acidic medium, prevents infections, and hence the presence of this commensal is very much helpful in preventing vaginal infection, thereby preventing the ascending organisms, so that the pelvic inflammatory disease is prevented. Next slide, please. Numerous studies using Nugent score and cultures have demonstrated that microbiota predisposes to occurring PID and sexually transmitted infections. That BV-associated vaginal microbiota. The largest longitudinal cohort study followed up 3,620 women quarterly for 1 year using microscopic evaluation and culture methods of endocervical swab and vaginal smears, and found that intermediate and high Nugent scores were associated with a 1.5 to 2-fold increased risk for trichomonal, gonococcal, and or chlamydial infections. In the gynec infections follow-through study in the United States involving 1,140 women, clusters of BV-associated vaginal microbiota identified by culture methods were associated with development of PID. So, bacterial vaginosis promotes the ascension of bacteria from the lower to the upper genital tract, or that BV may be an indication of upper genital microbiota tract colonization. Vaginal microbiota consistent with BV is a recognized risk factor for upper genital tract infection in both gynecologic and obstetric patients. Next slide, please. Next slide, please. Okay. So what happens when there is the alteration in the vaginal flora, and when the commensals are not there, there will be increased concentration of interleukin-1 beta in vaginal environment. And this triggers the generation of reactive oxygen species, and this affects the membrane integrity and flexibility, and impairment of both tail motion and spermatocyte fusion is seen due to this alteration in the anatomy of the vaginal epithelium. And what happens when the vaginal flora is altered? There will be decreased fertilization rate and also the implantation rate. Next slide, please. So, when the vaginal microbiome is disrupted, we could see various alteration in the immunological process of the spermatozoa reaching the upper genital tract, and thus there will be an impairment in the fertilization process. And when the endometrium is affected, obviously the implantation process is also affected. Next slide, please. So a healthy vaginal microbiota can help to prevent urogenital conditions such as urinary tract infections and BV. Therefore, studies leading to a better understanding of the vaginal microbiome will facilitate the discovery of improved treatments and diagnostics for such conditions. Next slide, please. So we need the vagina-specific probiotics. So probiotics containing lactobacillus is used over a long period and along with antifungals and antibiotics, particularly with the context of high infection recurrence rates. Next slide, please. According to WHO, probiotics are defined as live microorganisms which, when administered in adequate amounts, confer a health benefit on the host. Next slide. Prebiotics are compounds in food that induce the growth or activity of many beneficial microorganisms. So we call it symbiotics when it is both prebiotic and probiotic combined. So what are all the benefits of prebiotics? Improves the work of the digestive system, stimulate the growth and reproduction of useful microflora, and they maintain an optimal pH in the intestine, stimulates local immunity, remove excess mucus from the walls of the small intestine, reduce the formation of gases, suppresses the reproduction in the intestines of pathogenic bacteria, and stimulate peristalsis. Next slide, please. The vaginal microbiome as predictor for in vitro fertilization with or without ICSI outcome, a prospective study done by Cordner et al. So we need answer for the following questions. Is the presence or absence of certain bacteria associated with failure to become pregnant after an IVF or IVF-ICSI treatment? Can the composition of the vaginal microbiome be used as an independent predictor for IVF or ICSI outcome? Next slide. Our results, the results of the studies indicate that vaginal microbiome profiling using the IS Pro technique enables stratification of the chance of becoming pregnant prior to the start of an IVF or ICSI treatment. Knowledge of the vaginal microbiota may enable couples to make a more balanced decision regarding timing and continuation of the treatment cycles. Next slide. So a study from place is not there. Okay. Another study concluded that the results of the study strengthen the potential role of lactobacillus in promoting a favorable environment for pregnancy and suggest that microbiome characterization could be useful together with standard clinical and laboratory assessments in the pre-IUI evaluation of infertile couples. Next slide, please. So we have more studies on the importance of the vaginal microbiota. When the commensals are in the correct proportion, sorry. So we have more studies on the importance of vaginal microbiota, and the normal flora is really helpful in a very good reproductive function, and the abnormal vaginal microbiota will definitely interfere with the process of reproduction. Next slide, please. And there's another study on the relevance of assessing the microbiota in infertility, and technical advances in massive parallel sequencing have allowed the characterization of the whole reproductive tract microbiome in all the compartments beyond the vagina. The microbiota in the uterine cavity seem to be continuum from the microbiota in the vagina, but several works have reported significant differences between vaginal and endometrial microbiota, highlighting the relevance of assessing the upper genital tract microbiota to better understand the potential roles of bacteria and the physiological and pathological process taking place in the uterine cavity, including embryo implantation, pregnancy maintenance, and other gynecological diseases. However, the study of the endometrial microbiota, as with other low biomass microbiota, presents important hurdles because due to the small amount of starting material, they are easily contaminated by exogenous bacterial DNA. For this reason, careful and appropriate investigation of the endometrial microbiota is of outstanding importance to detect uterine dysbiosis that may impact the reproductive function. Next slide, please. So we have so many evidences that the endometrial microbiota has an effect on implantation success or failure. Next slide, please. So our aim is to start treatment as early as possible to prevent long-term sequelae of pelvic inflammatory disease. First of all, we should try to prevent a pelvic inflammatory disease by educating the vulnerable population on the healthy reproductive habits. And if at all the PID occurs, early detection and early treatment is of utmost importance. And the long-term sequelae can be the ectopic pregnancy, infertility, and chronic pelvic pain. And the other aim is to investigate and treat sexual partner in order to prevent reinfection. Next slide, please. So how do we do this? In case of severe disease, we need to advise rest, because rest helps in restoring the normality. And we have to rule out a pregnancy. And for pain, we need to provide them appropriate analgesia and the proper advice on how to protect themselves from sexually transmitted infections. And we need to trace the contacts for further prevention. Next slide. So the treatment depends upon the severity of the disease, and we need the broad spectrum antibiotics for the sexually transmitted infections, and for less severe infections we can treat them as outpatients, and for more severe infections we may need to admit the patient and treat them as inpatients. Next slide, please. So what are all the antibiotics that are helpful in PID? We can give IM ceftriaxone, and we can follow, that's the stratum dose, and we can follow them up with doxycycline and metronidazole for 2 weeks. And same way, we can put them on ofloxacin 400 milligram twice a day and metronidazole 400 milligram twice a day for 2 weeks. Next slide, please. What are all the other regimes? IM ceftriaxone stratum followed by tablet azithromycin 1 gram per week for 2 weeks, or tablet moxifloxacin 400 milligram once a day for 2 weeks. Next slide, please. When we admit a patient with more severe disease, then we have to treat them according to the findings. If there is any adnexal mass, we have to drain the abscess. And if there is generalized sepsis, then we need to treat them with more potent antibiotics. And whenever there is no proper response, that is expected response, then we might need to switch over to more potent antibiotics. And in more severe infections, we need to put the patient on IV therapy until 24 hours after clinical improvement and followed by oral therapy. Next slide. So the IV ceftriaxone 2 gram once a day and IV doxycycline followed by the oral doxycycline and metronidazole, or IV clindamycin 900 milligram thrice a day and IV gentamicin 2 milligram per kg loading dose, then 1.5 milligram per kg thrice a day, followed by oral clindamycin 450 milligram 4 times a day, or oral doxycycline 100 milligram 12th hourly and the tablet metronidazole 400 milligram thrice a day for 2 weeks. Next slide. Other antibiotics recommended are IV ofloxacin twice a day and IV metronidazole thrice a day, or IV ciprofloxacin 200 milligram and IV doxycycline 100 milligram twice a day, and IV metronidazole 500 milligram 8 hourly for 2 weeks. So surgical management is, in case of surgical emergency, but we resort to surgery when there is no response to oral therapy in clinically severe disease, but usually go for IV antibiotics in case of severe disease when we admit them in an ICU. And we have to drain the tubo-ovarian abscess if present. And those patients who are not tolerant to oral therapy, we need to put them on IV antibiotics. And in pregnancy, first of all, in severe cases of PID, we don't see pregnancies. So next slide, please. So when laparoscopy is needed is when we suspect adhesions, and if we see more adhesions on laparoscopy, and we do the laparoscopic adhesiolysis, and we drain the pelvic abscess. Sometimes, if we are not able to drain the pelvic abscess through laparoscopy, we might do a colpocentesis. We might need to do it when the access is not that helpful, easy through laparoscopy. So laparoscopy is needed when digital division of all adhesions and is found to be more helpful. So when laparoscopy is not really helpful, like when we suspect more of adhesions in the pelvis and we are not able to assess the POD, then it's better to do a laparotomy. And we can go for ultrasound guided aspiration in cases of recurrent pelvic abscesses. Next slide, please. So this is very important that we need to treat the partners. Current male partner of women with PID should be contacted, offered health advice, screening for gonorrhea and chlamydia should be done, and the treatment is given, that is IM ceftriaxone 500 milligrams straight term. And we need to educate them how to on protecting them from the sexually transmitted infections. Next slide, please. We need to follow up these patients because PID is lifelong. There will be acute exacerbations every now and then. So the follow-up should be a long-term follow-up. We should review the patient in 2 to 4 weeks to ensure adequate clinical response to treatment, compliance with oral antibiotics, screening and treatment of sexual contacts, awareness of long-term sequelae of PID, repeat pregnancy test if indicated, and repeat testing for gonorrhea and chlamydia after 2 to 4 weeks in those with persistent symptoms. Next slide. So thank you very much for the patient listening. And now it's open for discussion.
Thank you, ma'am. Thank you very much for that detailed presentation. It's always
Thank you very much for the opportunity. Sorry, because I have logged in through on my mobile, it's very difficult to look at the slides and read. Sorry about that.
Fine, ma'am. Ma'am, let me wait for 1 or 2 minutes for the participants to post their queries, ma'am. If there is query, then I'll read out for you, ma'am.
Yeah.
Ma'am, one question is like whether this PID can be treated during pregnancy, ma'am.
Actually, in cases of PID, because we are talking about the infertility due to PID.
Okay, ma'am.
So, usually during pregnancy, if there is subacute PID, we might see more of this exacerbation during pregnancy. That time we need to treat them definitely.
Okay.
But usually PID causes, a more severe PID causes infertility.
Okay. The participants, if you have any queries, you can just post in the chat box, so then I can ask the speaker for today. Ma'am, is there any increased risk of this PID during this pregnancy, ma'am?
Pregnancy is actually immunosuppressed state. So there will be immunosuppression during pregnancy. So whenever there is already subacute infection there in the pelvis, we can see exacerbation during pregnancy.
Ma'am, whether probiotics are safe during pregnancy?
Yes, definitely. That's the first choice. We don't usually prescribe antibiotics whenever we come across any infection during pregnancy. If we can manage them with probiotics, usually we start with probiotics.
Okay, ma'am. Ma'am, fine, ma'am. There is no questions in the chat box, ma'am. So if there is any queries, then I will forward to your mail ID, ma'am. You can address those queries through your mail, ma'am.
Thank you so much.
Thank you, ma'am. If you allow us, then we can end the webinar for today, ma'am.
I don't get you.
Ma'am, if you allow us, then we can end the webinar for today, ma'am.
Yeah. Thank you so much.
Thank you, ma'am. Thank you very much for spending your valuable time with us today, ma'am. Again, it was a wonderful presentation once again, ma'am. And ma'am, I'm looking forward for many more webinars in the future, ma'am. Please do some the webinars.
Definitely. Thank you.
Thank you, ma'am. Thank you very much.
Thank you.